everyone. WCTSMA and WAHOSA are proud to host this year's Diversity in Healthcare panel, and we thank you all for being a part of this collaborative event. Our event is being live streamed on the HOSA YouTube channel tonight, so a big thank you to those watching at home. If you have any questions that you would like to ask to our panelists during the call, please feel free to ask them in the live chat.
First, we would like to acknowledge that our schools statewide are on the homelands of Native peoples who have lived in this region for millennia. Currently, there are 42 tribes, 35 of which are federally recognized, that share traditional homelands and waterways in what is now Washington state. Some of these are nations and confederacies that represent multiple tribes and bands. We express our deepest respect for and gratitude towards these original and current caretakers of the region. As an academic community, we acknowledge our responsibility to establish and maintain relationships with these tribes and Native peoples in support of tribal sovereignty and the inclusion of their voices in teaching, research, and programming. We also pledge that these relationships will consist of mutual trust, respect, and reciprocity.
So, today we'll have the opportunity to learn about what exactly it means to be a healthcare provider and how challenges and successes are woven throughout all of our journeys. We will be asking questions to our panel members. These questions have been collected by our team from your guys' responses to our Google form and Instagram. On our panel, we have Dr. Margot Savoy, Dr. Jeffrey Kawaguchi, Dr. Ayu Ayaba, and Dr. Jody Roberts.
Dr. Margot Savoy is the Senior Vice President of Education, Inclusiveness, and Physician Wellbeing for the American Academy of Family Physicians. Dr. Savoy, please feel free to introduce yourself to the audience at home.
Hi, everyone. I'm really grateful for the opportunity to get to spend this time with you today. Looking forward to talking to you more about what it is to be a family physician and what it is to choose a healthcare career in general. So my background, and really briefly, I went to the University of Maryland for both undergraduate and for medical school. It shocks me every time I think about it, but I actually graduated from medical school 22 years ago. In that 22 years, I've had a really great opportunity to do a lot of cool things that I'd be happy to talk more about as we go through the evening. From practicing, so actually seeing patients, I get the pleasure of seeing people from the time they're born until the time they pass away, because I get to take care of the whole family in my job, which is really awesome. But I've also had the opportunity to teach medical students and residents who are training to be physicians. Now I have the opportunity to teach other family physicians how to be even better at their family physician career. And then I also get to do things like work on health equity and social determinants of health, do work in public health and other places. So like, honestly, I get to do some of the best of all of the things that I wanted to do when I was thinking about deciding to be a doctor almost every day in my job, which is super awesome. And I'm really glad that I get the chance to talk to you guys more about it tonight. So thank you for inviting me. I'm looking forward to the conversation tonight.
Now we have Dr. Jeffrey Kawaguchi. He is the Pacific University Athletic Training Education Program Director and the Northwest Athletic Trainers Association Ethnic Diversity Advisory Committee Chair. Dr. Kawaguchi, please feel free to introduce yourself to the audience at home.
Thank you. And likewise, I'm very honored to be part of this panel. Like was said, I am the program director at Pacific University, which is in Hillsboro, Oregon. I originally went to Washington State University and got my undergraduate degree. And then I went on to physical therapy school at Northwestern in Chicago. And to date myself a little bit, when I went to PT school, it was a bachelor degree program. So I have 2 bachelors, and then I practiced as a physical therapist for about 10 to 15 years or so. And then I decided to go back to school, and I got my master's in exercise physiology and my doctorate in sports medicine from the University of Virginia. And I went on to become the program director at Eastern Washington University. And now I'm the program director at Pacific University. I still remain even though I teach as my main occupation, I still am active clinically. I work as an athletic trainer on a daily basis at Tigard High School here in Oregon. And I'm also an athletic trainer for USA Basketball and US Figure Skating.
Next up, we have Jody Roberts, who is the head athletic trainer and sports medicine instructor at Wenatchee High School and serves as the chair of the Northwest Athletic Trainers Association LGBTQIA+ Advisory Committee. Dr. Roberts, please feel free to introduce yourself to the audience at home. I think Dr. Roberts just joined, so we can move on.
Sorry, guys, I seem to be having some connection issues. Oh, there we go. Can you guys hear me okay?
Yep.
Yeah, okay, perfect. I'm sorry, I didn't hear what you had asked me to do. I was having some connection issues.
You're good. Just if you want to introduce yourself to everyone.
Yes, hi, my name is Jody Roberts. I am the head athletic trainer at Wenatchee High School. I have two awesome people on our staff, so that's a really awesome benefit to have. And I've been teaching at Wenatchee High School for the last, this is year 3. I've been teaching in the secondary school setting for the last 11 years, and I just graduated with my doctorate in 2021 from Indiana State University.
Next up, we have Dr. Aliyu Abaya, who has been working as a public health specialist for the Global Fund for the last 20 years. Dr. Abaya, please feel free to introduce yourself to the audience at home.
Thank you very much. Thanks for giving the opportunity. I'm Dr. Aliyu Ayaba. I am originally from a small country in West Africa, Benin Republic. And I graduated there from medical school in 1994. I worked there in a hospital. And in 1998, 4 years after my graduation from medical school, thanks to American people, I got a scholarship from African American institutes to come to the US and study public health. So I landed in Seattle, University of Washington, and graduated from there in year 2000 in international health program. Then I embarked in an international career, working for UNICEF in Haiti, in Somalia, in Sudan. Those are very unstable countries, but I also work in stable country for Center for Disease Control and Prevention in Rwanda. For the past 10 years, I have been working in many countries also with financial support from Global Fund. And the past 3 years, I was called at the headquarters of a Global Fund for the position of public health and monitoring evaluation. So basically, my work is to support country to have a plan, to have the medicine and the knowledge they need to provide the health services to the population. And I'm happy to participate in the discussion around diversity, equity, and inclusion, because it is at the core of the work we do in war zone and in stable country. Thanks for giving me the opportunity.
Thank you all for being here on our panel. So let's jump right into the first question. If Dr. Kawagishi, you'd like to start off, the question is, why is it so important that people of diverse backgrounds are involved in medicine?
Yeah, in response to your question, I don't think it's specific to medicine. I think it's every form of walk in life that we journey through. And it's not just diversity of race and ethnicity, it's also diversity of thought and beliefs and religions. This is where great ideas come from. This is where creativity comes from. This is how we solve the world's problems. So until we realize that it's the diversity of people that make what we do worthwhile and continue to move us forward, That's why it's important in all walks of life.
Would
Are we
anyone else on
are
our
we
panel?
allowed to jump in if we have a thought?
Yes, ma'am.
Yeah, so I actually do think that the idea about having diverse thoughts and opinions and perspectives is super important, but I think we can't overlook the fact that there is real data that shows that there are groups of people for who their provider or clinician or the person taking care of them in a healthcare setting makes a difference to how they receive their care and how their care is delivered to them. So that whether we want to be excited about it or not, or happy about it or not, racism is real, sexism is real. People don't always hear people the way that they need to be heard. And there are actual data and studies that show that, sometimes having a woman doctor for another woman means that she feels safer and better able to share her story. It also means that she might be heard and that her diagnosis might happen sooner. That if you have a person who is, African American, that they might actually get better care and have better outcomes if that care is being delivered by another African American physician. And I don't think it's about the race necessarily. I think it's about the ability to hear and understand people and understand the shared background and the diversity of experiences that people bring to their healthcare, but then also to the clinician or the physician side of it. But I think that there is something to be said for the fact that we have systems of power that impact how we deliver healthcare, particularly in the United States of America, but I think it happens across the world. And until we're able to undo some of that systematic work, you have to make sure that the voices are available to point out where there are places where there's gaps and where you're missing thoughts and ideas and opinions, and make sure that everyone has the opportunity to be heard and to be seen and to be cared for in a way that that makes it possible for them to both receive the care that they need, but also to be offered the care in the first place in a way that's fair and equitable.
I'd also like to say diversifying our skill sets that we're able to offer patients. My research was on something called health literacy and minority populations. And one of the things that I stumbled upon, which should have been something that I knew, was the lack of healthcare providers in athletic training anyway, that we have that are bilingual. And so there's a facet of, there's a large amount of ethnicities that aren't able to overcome, language barriers because we don't have systems in place to support those needs if you're in a setting similar to mine. And so having people that have diverse skill sets, not just in the healthcare that you provide, but the things that in the background, you're able to speak to, more people and connect with more people and be seen and have them be seen.
I can add that it is important to have diversity among healthcare professionals because it is also a result of a diversity in the education sector. If diversity was not applied over there, we wouldn't have doctors, nurses, and midwives reflected in diversity. That's the first reason that we should advocate for diversity in all the sector. Secondly, for the program I'm familiar with, there are certain services, like all over the world, the HIV program I manage, there are certain services like home-based care to people living with HIV/AIDS that are better delivered by the peer. The same thing applies to LGBTQ program that we have, and those people have the ability and understanding to better serve the peer for certain services. So the more diversity, the better. Over to you.
All right. For our second question, what positive effects in your field do you see as a direct result of diversity in the field?
And so for me, I think it's so family medicine by definition is diverse because we show up in so many different places in the world and in the country. So for example, in the field, you have to think about things like geographic diversity. So there's some family doctors who practice in rural settings and some family doctors who practice in urban settings. And the things that they need might look somewhat similar, but they have to know the community and the place that they're taking care of to be able to deliver the care potentially in the way that the people can actually get it, right? So what you have access to in one place may look really different than another place. Some family dogs do global health and they show up in places that look entirely different than places in the United States, and they have to be able to deliver that care. So I think when I see people thinking about diversity in the sense of like geographic diversity and skill sets and things like that, it shows up in this opportunity to show up and be what your community needs you to be in the place that you're at, and so that you can actually deliver the care that they need from you. I also see it showing up in the diversity of the types of people choosing to go into the field. And so I see that showing up in lots of ways. So, I mean, one of the things that I think makes me most excited is the specialties acceptance and willingness to deliver care to anybody when they show up and they need it. So I think about things like, you know, gender affirming care, and I think about things like some of the things that people sometimes push back on or don't think need to happen. Your primary care physician should be able to do that for you. Like that should be a safe space where if you show up and you want to be able to get your care, you should be able to do that no matter who you are. And the idea that people are diverse enough to be thinking about it, willing to learn about it, willing to be open and receptive to learning new things that maybe they didn't learn when they were in medical school, that are now things that are available. Like all of that feeds into diversity for me, and thinking about how you can really be open-minded and willing to take on new challenges and really be able to support people where they need it. And I think medicine changes so much and so fast that if you're not willing to do that and not open to that space, that you can't do that. And I love the fact that in family medicine, people they just have that spirit, and they think about that team-based way of thinking about how we could approach challenges. And that allows diversity of thought too, because you don't even need to have all the same specialties. You don't even have to have all the same degrees and backgrounds. There may be a whole variety of people who could show up and really help get the patients the care they need. So, I mean, that's just some of the ways that I see diversity showing up in family medicine in ways that make me really proud to be a family physician, but really excited as a person who's a patient and might need care to know that people are thinking about those things and being prepared to take care of me when I need it.
And I would add that I think Dr. Savoy put it very eloquently in her first response, that when you see someone, when you walk into the doctor's office or the physical therapist, and you see someone who looks like you, who has similar beliefs, is open to your diversity of thought, it just makes you feel more comfortable. And I think the research does show that the care that is provided increases with that comfort level.
I'll add that at organization level, when diversity is practiced, the direct effect is the performance of the organization, where all the staff, they feel a sense of belonging, they produce, they perform well, and also it really empowers them to seek diversity in the population they serve. If all groups are represented diversely in the staffing, then it should be the same in the community. And then we look at the data and see if all groups really are represented in the people we serve in the facility. And then we are able to design specific outreach projects to reach the people who are not coming. So diversity is important for organization performance and productivity. Over.
All right. Thank you. So, as an extension to our last question, how has your identity impacted how you interact with your peers and patients?
I think one of the things, leaking from the last question to this one that's important to say is having those communications with your patients, or having it visible, the type of diversity that you're able to bring to the table is really important. We don't always wear our diversity all the time. I serve the LGBTQ plus group for the NWATA, and that was kind of a difficult thing for or I felt oddly uncomfortable having that conversation with a high school population because I work in a secondary school setting, and knowing, you know, even though it's part of my identity, you know, maybe it's not well accepted or, you know, those types of things, but having the communication with the people that you work with and the patients that you have, and just, you know, showing that you're parts of these groups, that you support them, the people who want to be a part of that message, or the people that want to be a part of that diversity, will find you. And the rest who could care less or aren't involved in that capacity, you know, will go seek people elsewhere. So, you know, your identity impacts our identity impacts our work immensely. But if we're not outgoing with what our identity is, if we're not willing to share those things, then I think it's difficult for people to buy into the diversity you're able to gift your patients.
I think for me, I would say that my personal identity has been a double-edged sword throughout my career, because there are times when it has been incredibly helpful for me and made it possible for me to relate to either the students that I was teaching at the time or the patients that I was taking care of at the time, because we had shared background and shared experiences and things that have happened that made it easy for us to relate or easy for us to connect. And then there have been times where, honestly, it was used against me. So that, you know, there are some people for whom having a Black doctor is a problem. And they'll tell you right up front, and, you know, you have to deal with those emotions and those feelings. There are some people for whom having a female doctor is a problem. And they'll take exception and have feelings about that. I actually don't identify as LGBTQ, but I feel very strongly that people should have access to care. And for me, that's not a challenge. I just don't see that it's a big deal. Turns out you can be held in weird ways about that too. So some people take exception to the fact that you're not part of the community and you're trying to do things in a community that you're not a part of. And so there's been some weird dynamics that have shown up in different ways for me, like over my career. The beautiful part, though, is that I think that's life. I mean, I think that's literally just the experience of living. And the more that you're able to think about it, talk about it, show up and be in spaces, the more that you can help other people navigate those spaces too. And your ability to show up for people makes it possible for somebody to have a space where they can feel safe around you. And you don't necessarily have to take the negativity as being negativity directed at you. Sometimes it's their own problem that they need to go deal with on their own time. But your existence matters. And the more common experience, and the thing that always sits with me, is how often my literal existence in a space has made someone else feel a positive thing, where I've seen patients who had never had a Black doctor before, and it was the most meaningful thing to them to think that someone would actually get the chance to go to school and be able to do that, because that wasn't something that they were allowed to do when they were my age. They wouldn't have been allowed to do that. They wouldn't have been allowed to have that opportunity. And for me, that makes me incredibly proud and has driven me to want to do more things and really reach back and make sure that people coming behind me get to have even more opportunities than I have available. And so for me, you know, it's been an interesting back and forth, because sometimes, you know, even your peers can surprise you. Like, not everyone necessarily comes from a background where they've met people with all these sort of different experiences. And sometimes your peers can say some pretty insensitive and ridiculous things too, and not realize that they're harmful or hurtful, because they're just not necessarily knowledgeable about who you are or where you come from. And when I think about my own blind spots in life and where there have been times where I've been taught a lesson, I think about things like, you know, not everyone who has a disability looks like they have a disability. And so you may be saying things about a person that is hurtful, and you don't even know that person is in that group. And just the number of times where I think about places where people haven't thought about that their words matter and how their existence matters, and that also happens the opposite way, where you could be inspiring people and making them think that they have an opportunity and a chance just because you exist. And so to me, it's a double-edged sword. I see it happening both ways. But it's why I double down on encouraging people that shouldn't be what stops you. And so if people are saying crazy things to you, or you're feeling some kind of way, or you feel like you don't belong, or like you're not supposed to be there, even if you're the only one in the whole room that is there, that looks like you or thinks like you, that's all the more reason why you should be there, as opposed to the reason why you shouldn't be there. Because to me, your identity isn't usually just you by yourself. You might be the only one who everybody knows about, but you might actually be like helping other people to be able to step into that space and do that work too. So for me, double-edged sword. but almost always at the end of the day, I can find the positive in it.
I could add from humanitarian work perspective that my identity as an African doctor working from organization mostly funded by Westerners also has a double-edged consequence. On a positive way, most organizations working on global health, they invest in developing country, particularly where I come from, Africa, where we have many health issues. And the organization rely on us, people like me, who have been trained in those countries and know the context and are able to guide the investment in healthcare in those countries. And we are valued for that, for our skills and the way we contribute to those organizations. On the downside, sometimes I also feel frustrated that those health issues are our issue. And some of our governments are capable of really funding largely those issues, but they don't do often. And then it is other countries who will fund that. So it affects us in many ways, but mostly from my own experience, it's very positively that we are able to guide investment of billions of dollars to our country. Over.
I guess when I read this question, I approached it a little bit differently. My identity, I will be the first to admit, comes from my parents. My father was in prison camp during the war, just a few miles south of where I now live. And a day doesn't go by that I am remembered of or reminded of his lessons, and has taught me patience, has taught me compassion, has taught me understanding. So everything that I am and every act that I do is premised upon those teachings and what I learned growing up. So that's how I approached this question, was really from a very personal perspective.
All right. So for our next question, it's how do you stay motivated in the face of discrimination?
It's interesting, like your answer to the last question is sort of where I would have started with this question. Because the thing that keeps me motivated, even when it feels like the challenges feel insurmountable, has always been the fact that I know that I am blessed to get to do the things that I get to do, because it wasn't even an option for my grandparents. Like this wasn't even on the table. Like going to college wasn't on the table. That wasn't a thing. And then, my parents get to go to college, and then here I am, I get to be a whole doctor. I mean, like, there's not anybody in my family that got to do that. And just the idea that I get the privilege of being able to do that is super exciting to me. And the thought that I might help other people realize that they too could do that is really motivating to me. And so even when I find that, people might feel some kind of way about your existence on this planet, there's usually a reason why they're upset, and it's usually not about me. It's about something that's going on with them. And so my job isn't to get distracted by them and their issues. It's to find ways to make sure that everybody else is getting the things they need. And honestly, a lot of it really does come back to this idea of just remembering that I stand on the shoulders of giants, and they didn't get the opportunities that I got. So I have to do bigger things because I've got to make them proud. And that to me is a lot of where my motivation comes from. And then making sure that people get the care that my parents or grandparents might not have gotten, because I make sure that they learn how to deliver that care in a way that's culturally sensitive and thoughtful and acceptable to them. So that me making sure that I teach other people how to make that happen is literally my life's mission.
When I read through this question, this was a tough one, because I'll be the first to admit that it's hard. It's really, and it's interesting this question comes at this time. You have to understand, I live and work in Hillsboro, Oregon. And somebody asked me once, how many times I get harassed, how many times I face discrimination. And in Hillsboro, Oregon, which is just a little west of Portland, I would say on a monthly basis. On a monthly basis, someone will yell something at me or say something discriminatory. And it's hard. It really is. I guess what motivates me is, remember, I'm an educator. Is to see faces like I'm seeing on this screen and know that it's my opportunity to make the world a better place, to make healthcare more accessible, to provide a pathway so that the road that I follow is not as difficult for you all. So I think that's my motivation, is the faces that I'm looking at right now.
I have to agree with that. I think, you know, I've worked from the age of 23 professionally. And I'm a people pleaser by nature. And so whenever I've faced discrimination for anything, it was, I was, grin and bear it, put up with it. Maybe you don't completely recognize it, like microaggressions that are said. And I think particularly when maybe you're a younger person, I think I recognize now, in the last couple of years that I'm a lot more, well, I'm not going to stand for this and I'm not going to put up with that and these types of things. And so when I face discrimination, maybe it's not even for myself, but I think about how important it is that I advocate for youth that are being discriminated against. That's my motivation, because I knew what it was like to not feel like anyone cared about what you had to say, or feel like they were able to bully you simply because of your age. I faced a lot of that. And so my motivation is, like Dr. Kawaguchi said, is to stick up for people that maybe don't feel strong enough in their voice yet, because it was a second ago I felt the same way.
In the organization I work for, discrimination is very rare, probably very subtle, because there are systems there to monitor and action are taken when it is discovered. However, frequently I see discrimination against the client I serve in hospitals, people living with AIDS, LGBTQ community, and my motivation is to continue to support them. Sometimes I feel like discrimination also comes from ignorance. So my motivation is also that in our program, we have programs to address those issues, to bring the knowledge and to put systems in the community, care facility and organizations, local organizations, to fight about the discrimination as we do in the funding organization.
Thank you guys so much. So in the topic of overcoming biases, what strategies do you employ to overcome personal biases when delivering healthcare services and ensuring fair treatment for all patients?
So Dr. Kawaguchi was actually my professor when I graduated with my bachelor's degree in athletic training. And one of the things that, he taught us and implemented that program is making sure that you're taking the time to get educated on the biases that you might have, and really self-reflecting and identifying where those things might be present in your life. I was the first one to say, there's no way that I'm biased against anybody. And maybe not outwardly, but the lack of knowledge, the naivety that was there, particularly when I started earlier in both my education and in my profession, that leads to biased behavior. So just staying educated and staying up with current events, making sure that you're understanding new, politically correct terminology and those types of things, I think is extraordinarily important.
I think those are great points. I mean, for me, I think appreciating the fact that no person is not biased, like everybody's got a bias. Everybody's got some bias. And that's okay. It's actually okay. Like there's biological reasons why we have biases for certain things. The question is, what are you going to do about it? So like it's not necessarily that you have the bias that's the problem. It's how you manage that and what you do with that becomes the problem. So recognizing where you're stereotyping people, lumping people, grouping people and not thinking about them, thinking about a group and not the individual who's in front of you is where, for me, it gets to be a bit tricky. So that sometimes it gets very easy to like categorize groups of people so you can get through the day faster because you're taking care of lots of things and lots of things that seem like they happen a lot in certain groups. So that must be all the groups. The next thing you know, you're treating a group of people in a way that isn't really appropriate or doesn't make sense. And so I think for me, a lot of it is constantly pressuring myself to remember that we all have biases and none of us gets out of it without it. And the job isn't to try to eliminate them. The job is to try to mitigate them and to think about how you can be better at it. And the way that I tend to get better at it is by learning how to listen and stay curious. And so instead of jumping to conclusions, instead of trying to create my own narrative for the person sitting in front of me, is really trying to learn more about them and get curious about their behavior, the things they're doing, the things I don't understand. And I have found that most of the time, I just learned something new. And in that learning of something new, it opens up another door and another space for me to grow. And as I grow more, there's one more thing that I now am a little bit better about. And that has helped me sort of stay centered and grounded. The other thing that I have, as I've gotten older, and I'll be honest, like, I mean, as a younger doctor, I don't know that I was smart enough to think about it, but as I've gotten older, I've gotten really thoughtful about giving patients the permission to interrupt me and to correct me so that they may or may not know that they are allowed to interrupt me or correct me. Like, and if I've gone off on a tangent and this isn't where you meant for me to be, if this isn't where we were supposed to go, if I've jumped to a space that is just not the space where we needed to be, I need you to tell me that because I'm not doing it on purpose. So that's not where my heart is. And I try to tell people as often as I can up front that like if we end up in a place that's not healthy for you or healthy for me, we need to talk about that. And so you have to tell me, like you got to interrupt me and tell me so that we can course correct and get back to the right spot. Because if you walk out of the office feeling some kind of way and you didn't feel safe enough to tell me, I failed you and I failed the interaction and I didn't give you what you needed. And that for me was an interesting one because I never thought I had to give people permission to interrupt me. But that power dynamic of you being the clinician and them being the patient is real. And giving them that permission to be able to help you be better for them makes you back to being partners. And I think that's where, for me, it doesn't make my bias go away. It doesn't necessarily make me any better a human being per se, but it certainly gives me an opportunity to try, right? I mean, so, each time I get an opportunity to fix it before they walk out the door. And if I make a mistake, which I think sometimes we don't give people enough grace that you're going to make mistakes. If you make a mistake, you get a chance to apologize and fix it, as opposed to doubling down or tripling down on it because you didn't know it was a mistake, or just not even having the person feel safe enough to tell you. And so for me, those are just really concrete ways that have made it a lot easier for me to be better at it. But I will tell you, I think it's a journey that you never actually land. Like, I don't think you ever get to the part where you're like, I'm suddenly bias free. Like, I just don't think that happens. I really feel like it's an ongoing, lifelong mission to keep getting better and to keep doing better for the person that's in front of you.
Yeah, for me, well, first of all, it amazes me that Dr. Roberts learned anything from me, which continues to amaze me. But I agree with all of the points that have been made. And most recently, I've caught myself quoting one of the most famous contemporary philosophers, that being Ted Lasso, who said, "Be curious, not judgmental."
And without taking it away from anybody, how this is supposed to be set up, but the next section is talking about intersectionality. You have to treat the person first. You have to get to want to know who this person is. So keeping that curiosity in mind is really important. A huge lesson that I learned was recognizing my privilege. Around the same time that I was learning to recognize my bias, I was really, really learning about my privilege. And I think being the voice of saying, like, these are my privileges. I wear these privileges. I'm bringing these privileges to every single thing that I have. I need to stay humble enough to recognize that the people that I treat are not me with my privileges, and staying curious about, what it is other people have faced and their privileges and their biases, and the beautiful thing that they bring to our clinics is what we have to do. We have to stay curious. I love that.
Yeah, so our next question is, how does considering intersectionality, the interconnected nature of social categorization, such as race, gender, and socioeconomic status, influence your approach to patient care?
I'll start with this one. When I think of intersectionality, I don't have to look further than people like Dr. Roberts, people like Jake Howell, who you guys are all very familiar with. It amazes me to see what amazing individuals they've become. And to have over the years gotten to know them and to see how all of the components of their life and the way that they were raised and their beliefs and their thoughts all intersected. And they really teach me a lesson every time I approach a patient, and remembering all of the things that make them up is the same things that make up everybody. It's all of these differences, all of the components. So intersectionality to me is, you have to remember that everyone is an individual and everyone has all of these things that make them up. So I don't have to look very far to get great examples of how important that is.
I will add that intersectionality materialize really where diversity and equity meet. You have diversity, but you also have different groups, different people that have different needs. So in my work, we constantly are monitoring, doing survey to see how diverse our client groups are, what are the specific needs of each group, and be able, you cannot provide like one size fits all services to the community. Sometimes we call it positive discrimination, but yeah, we need to be looking at that and make sure we identify vulnerable groups in the population that need specific services. And in the work I do, we design targeted programs to be able to meet the needs of those populations. So yes, diversity is good, but equity also should be a component that we look to be able to meet the individual needs of each subgroup of the community.
I thought learning about intersectionality was one of the most fascinating things, partly because I had all kinds of aha moments about things that I never really thought about one way or the other, and why there are sometimes some shared experiences that don't make sense to groups of people, and why sometimes groups of people can collect together to provide support in a community for one another, and that there may be ways that you could connect people a little different. And so for me, I don't just think about it how it approaches my patient care, but it also comes up about teaching and how you educate and how you sort of spend time in the world. But for a first part, I thought it was fascinating to think about this concept that life is hard. Like, so no matter who you are, it turns out life is hard. So even if you were the richest person, like with all the stuff, it turns out life is still hard. It's just a different kind of hard. And those different kind of hards level up or level down sometimes, depending on the other kinds of hard that get layered on top of it. And so there are times where your kind of hard and somebody else's kind of hard aren't equal. And so that, back to the curiosity thing, getting curious about what's creating the barriers and the challenges for them, as opposed to jumping to assumptions about what they're not doing, what they can't do, what they're unable to figure out, is revolutionary in this idea about managing patients and helping them manage their own lives. Because what I find is that sometimes people are very quick to make assumptions about groups that aren't always as easy as we want them to be. So the best example that I can give you is that obviously I'm an African American person. As a Black person, I spend a lot of time with other Black people. All Black people are not a monolith. We are not all the same. We were not all raised in the same place. We did not come from the same background. We did not have the same intersection of what I may see as a Black woman who identifies as cis and heterosexual may look entirely different than a Black woman who identifies as queer and who comes from a rural community and who is from the South and Baptist. Like, we are just not the same people. So we may have some shared experiences and things that, we may go to the same hair care aisle in the store to get the stuff to do our hair, but we may not have the same ideas about other really core fundamental things in our life. So if you walk into that room and you make the assumption, I'm a Black woman and you're a Black woman, we're exactly the same, you might miss a whole boat and a whole space and a whole place. In the same way, if you walk in the room and you're like, you're a Black woman and I'm not a Black woman, therefore we have nothing in common, you also miss out on some really key intersections that might be more foundational for that person versus you. And I will never forget the time that I was having an entire conversation with a patient. And at one point, she paused me to let me know that from her perspective, being Black wasn't her number one problem. And I was like, I'm sorry, what? Like, you're a whole Black person in America. Like, of course, being Black is your number one problem. And she was like, it absolutely is not. My number one problem is the fact that I'm transgender and Black people hate me just as much as white people hate me. And so I actually have a whole other problem. And I was like, now that you mention it, that's a good point. And then she went on to point on the fact that she actually has a disability. And so she can't always do some of the things that other people would want her to do. And it's not an easily visible disability. So she gets really fatigued and sometimes literally just cannot do stuff. I mean, the idea of moving is more than she can think about. She just can't move. And so people can't wrap their head around that. So they're like, you clearly must be lazy. And so there's this weird disconnect for her where she's like, honestly, the community that supports me around my chronic disability, and my community that supports me around my sexual identity are more supportive to me than the Black community is to me. And while I appreciate that I experience racism and that there are things that are taken away from me because of that, that actually isn't my number one problem, identity, challenge. It's not even the way I see myself. I see myself first in this other space and second in this space. And I just thought for me that it was an amazing conversation. I just learned a lot from her. And I learned a lot about how I could help connect her, the things I could do to make her life better. But it also opened up my eyes to the fact that my bias is that, honestly, I know I have woman issues and I know I have Black people issues, but it feels to me like the Black people issues seem to be the bigger one. Turns out that's not true for all Black people in America. And we actually were from a similar town in a similar part of the country. And we had a lot that was very similar, but that was fundamentally different. And so this idea about, putting the patient in front of you first, putting their family and the context that they're in first, thinking about what they need and how they're presenting to the space. And then, I know we can't say this enough, being curious about why they're choosing what they're choosing, how they're getting to that answer, why do they believe that, changes your whole life. I mean, it literally just changes your whole life. And the same thing is even true in your friend circles and in your peer circles, that, your peer says something to you that doesn't make sense. And you literally just ask them, how did you come to think that? Why do you believe that? And sometimes they will say things that just really change your perspective and change your life. And so just that being curious and asking questions has made a big difference, and understanding that not everybody's priority line is the same. And the better that you can get at aligning their priority line, the better you can get at helping them choose the care that they need to live their best life, which for me is, in primary care, that's really my job, is to make you live the longest, happiest, healthiest life that makes you happy. And that priority list may look different for you than it does for me. And so intersectionality plays a big role in that, because all of those things come together to make you who you are. And if you miss even a part of that, you still may not get the person to their happy, whole, fulfilled self. You may be missing something out.
Well, in the bottom, what I have to comment on all of our answers is that we've allowed space for this curiosity to be, fulfilled. When I first started, it was, I thought the name of the game was how many patients can I see? How quick can I turn them out? And, regroup and just do. And it wasn't until the last few years that I really allowed myself to slow down and ask questions and learn about people and those things. And so I think being I don't know, not a pioneer, but if you work in an environment where it's go, 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 sometimes you're the only one who takes the time to ask. And if you want to be, it's not even a good healthcare professional. If you want to be a healthcare professional and do that job, you have to make space for those conversations. You have to prioritize them.
Thank you. Would anyone else like to add to the last question? All right. So we have a great question from the chat. Do you think that access to healthcare, especially by those from underserved backgrounds, is affected by price?
Yes.
Yes.
Yes, unfortunately.
That's one of the things that I love about athletic training, that I didn't expect to love from athletic training. And you know who taught it to me, Dr. Kawaguchi, was you again. Another thing that I learned. We had a big conversation once about, it was really when we were trying to get insurance involved in athletic training. Yeah, and I don't really know the whole history of that, but one of the things that I have learned to really appreciate is that I'm not competing with anyone telling me how many times I can see a patient, the things that I can do during that time. And it's allowed me the opportunity to set things up appropriately. But that's only for my job. My job is paid for by a school that says anybody who fits in this particular population, come on over and be seen by this person. She works from this time to this time. And if I need to refer people, that's a different set of hoops that they're going to have to jump through. So I pray, I hope that there's things that I'm able to do for them so that price in that capacity isn't determining the care that they get. But I know that I'm not the only healthcare professional that they see, and that price influences it.
I think this is an interesting question because I would actually expand it out. It's not just price, it's cost. Like just the fact that there's a cost associated with it. And healthcare is bigger than healthcare. Healthcare is actually more health. And so it's not just whether you can afford your insurance or not. So we've seen even when you are able to give people insurance at a low rate or at no rate, even when you're able to give them medication, for example, at low cost or no cost, if you don't address the other determinants of health that are impacting their ability to take care of themselves and to do the things that they need to do, they still don't ultimately get to the level of health that they deserve. And so they're being underserved, ends up getting doubled down on by economics that happen around, their housing, the ability to have a pollution-free environment, the ability to have food that's fresh and water that's clean, and things that just seem so basic, but those things are not a guarantee or a given in the United States of America today. And so for me, it's not even just price, it's cost, and cost that then balloons out to this bigger thing that impacts people's entire health. Because even if I give you insurance, even if I give you medication, if I don't fix the really messed up situation that I send you back home to, you don't get well. And in fact, you have generations of people that just don't get well. And some of those communities we built and created, and we continue to keep people in those underserved spaces through our approaches to other things that, drive poverty and make it difficult for people to sort of move their way out of those spaces. So yes, I absolutely think it's driven by price, but I also think there's a bigger financial and economic challenge that we have to talk about.
Access to education. You can give them low cost, no cost, but if they don't know how to prevent problems, maybe their culture, food is a big part of their culture, and the food that they consume is not beneficial to their long-term health. If you don't have people that take the time to educate them, or if they don't have access to that education, good education, up-to-date education, they are going to continue to be underserved.
I will add that, yeah, cost, healthcare has a cost, cost for the offer first, because the service has to be available. Even if you are rich, you are looking for the service, where do you find it? You find it where it is available. If I look at the country I have worked in the best case scenario, you will see 30% of the population are living in more than 5 kilometers from any health facility. And they don't have cars like public transportation like in the Western world. So even with the offer, we have issue. And now for the demand, if they don't have insurance, or if they are discriminated on, they also cannot afford. And that is the result. You will remember in the 90s, World Health Organization issued a statement, health for all, in the year 2000. Today we are in 2024. I don't see any country where health is for all. We are talking about universal health care coverage by year 2030. So it is really not ending game. It's a challenge. And I think all government organizations, individuals have to be aware that there is that cost, and how do we fund, how do we finance healthcare so that it doesn't impact the health of the underserved population. And I echo the statement of clarification for Dr. Margot. It's not only where even the offer is there, the demand is there, you get the health service. When you go home in Africa and you don't have a bed net to sleep, then you will get malaria. You don't have running water, you don't have sanitation. So there is always a cost to that. And that is the responsibility of all the international community to be able to give each community the basic health care they deserve. Over.
Thank you. Our last question is, do you have any tips on how to better advocate for yourself?
So I guess my best tip is the hardest thing that I could probably tell you, because it sounds really easy to say, but it's incredibly hard to do. And that is that you just have to be brave. So honestly, the worst thing that somebody can say to you is no. And if one person says no, there's like a bazillion other people you could ask. And so it's not that they're the end of the line. And I think that oftentimes we limit ourselves because we said no to ourselves inside our head on behalf of the person or the people who we were going to go ask or try to do something with. And they may or may not have actually said no. And if we could have just been brave enough to ask the question, or just been brave enough to push back, or just been brave enough to fill in the blank, whatever the thing is you need to do to advocate for yourself in the moment, that the vast majority of the time, the worst doesn't occur. It actually is very rare that the really big catastrophic thing that you imagined in your head was going to happen actually happens. And more often than not, which surprises me to say, because I was a bit of a chicken as a younger person. Like I just, I was a bit of a chicken. So I've gotten braver as I've gotten older. And as I've gotten older, what I realized is that like most of the time, my creativity and coming up with ways that bad things could happen to me is far more interesting than what anybody's ever actually done to me. And so most of the time, the people have either been like, hey, that's a great idea, or no. And then I'm like, hey, that no is not a real no. I'm going to come up with a new idea and come back to you. And so just be brave. I mean, like, honestly, be brave. And I'm not saying go out there and like set people on fire and try to be crazy or weird or like yelling at people or do bad illegal things. We're not talking about any of that stuff. I'm talking about just standing up for yourself, standing up for the people who you value and who you want to stand up for, and just being brave. And being okay with the fact that sometimes you might get a no, but that doesn't make you any less important, doesn't make you any less smart, it doesn't make you any less good. It just means that sometimes they say no. And I think that was really hard for me when I was younger. And I'm glad that older me knows that. And I hope that younger you can hear older me say, I used to be you. Be scared and do it anyway.
I think too. Oh, go ahead.
I'm very glad that Dr. Savoy said that. That's one of my favorite lines. And I'm dating myself again, but one of my favorite movies is the BFG, the Big Friendly Giant. And she told the giant to be brave. And I have students who give me plaques and clocks that have that on there, and I must say it a lot. Another lesson that I learned in my many journeys, one of my opportunities, I got to spend some time with Carol Lawson, who was a basketball player at Tennessee. She's now the coach at Duke. And I'm hoping that you have all seen her video when she was coaching, and she talked about when things get hard. Hard never gets easier. Hard is always there. But extraordinary people they don't sit back and say, oh, I hope things get easier. Extraordinary people just deal with hard better. And that's something that I always try to remember. But yeah, I agree. Be brave.
I think you have to be willing to walk away too, and knowing when that is. And that was one of the hardest lessons that I have ever had to learn, was being willing, advocating for yourself and believing in yourself so much that when anything is against how you think things should be, or you don't feel like you're in an environment that is supportive of you and your vision for your healthcare, you have to be willing to walk away. And I'm the kind of person, I do not like to be told no. I'll find 50,000 ways to go about something, new ideas all the time to get what I want done, to get what I want done. But sorry, the greatest thing I could have ever done for myself though was being willing to walk away when you knew there was no more room for growth for you.
I can add that very few people are brave enough to really advocate for themselves. I think they need the supportive environment to be able to advocate for themselves. I look back and I see we train young girls in Africa for life skill. What we have life skills so that they can defend themselves against gender-based violence, unwanted sex, or something like that. But when they go home, when they go into the community, they cannot always express, exhibit those skills when the culture, the environment, the institution are not there to support them. In a hospital I supported, we don't hear about clients voicing themselves against the provider until we do periodic survey, client exit survey, to hear really what they feel about the quality of care that they are receiving, and then we are able to take action. So if there is no institution to do those kind of things, it will be difficult. It will be hard for individuals to really advocate themselves. So institutions, the government, associations have the duty to create those environments so that individuals are able to voice and advocate for themselves.
All right, so to wrap things up, we just want to give a special thank you to all of our panelists for coming and speaking with us today. Each one of your presence means so much to us. We all gain great inspiration and insight from all of your stories. And of course, we thank all of our attendees for joining and providing us with these thought-provoking questions that guided the panel today. If you all have any other questions for our panelists, please feel free to reach out to your state officers who can then connect you. This meeting is now adjourned, and we hope you have a great night and see you all soon.